afternoon, everyone. Thanks for joining us. It's 1 o'clock, and we're going to get started with Access Care 101 with Joe Kozakowicz from the TriCare division of our D357 Southwestern OTSG. I'm at OTSG, and Joe is down in San Antonio. I'm going to let him take the reins. Thanks for presenting, Joe. It's all yours.
Thank you very much, Sarah. I need the thing to allow me to share my screen. While I'm waiting for that to come up, some of the pre-questions that were asked yesterday, I'll be addressing as we go through, but just for thought why I'm waiting, okay, it's coming up now, is how do you measure if a template maximizes the productivity of your positions? Some of the things we need to be looking at, eventually we're going to be doing, that's going to be outcomes driven, but right now we're looking at RVU generations, we're looking at do you have enough appointments to meet the empanelment? And I'll be showing you some basic equations that will help figure that out. Where to get the access to care data, I'll be bringing up the talk. I also use CHCS and M2, and we'll talk about that more in depth as their questions present. How to see if physicians are meeting the access standards for their panels. The best ways to do that would be the PCM continuity metric and looking at your leakage. And I'll show you a way on the PCM continuity tool to look at where leakage is also occurring within your facility as long as it's within your DMIS. And then I'm going to be talking in depth starting with the third available. Let me bring that up now. Okay, you should be now seeing a slide that says third available appointment primary care methodology and variations dated 5 December 2012. The third available appointment methodology we know has made a lot of people want to pull their hair out over the last probably about 2 years. Please understand that this is not, first off, a Army metric. It is a Health Affairs mandated metric, but the Army is definitely starting to influence how this metric is being calculated. And we'll be discussing the way it is being calculated today, and we'll also be looking at the way it's going to be calculated here in the very near future. All it's waiting is to be presented to the SWIG for final approval. It's already gone through the council. First off, the purpose of the third available appointment was to reflect the availability of the clinic to maintain provider availability in a given access category. Well, what does that mean in short? It was a first attempt at gauging, is there access out there? i.e., are there appointments out there? The problem is this graph kind of misrepresents something because it shows it as looking at the first appointment, the second appointment, and the third appointment. Well, what it in fact looked at, the way the ad hoc is written currently, is it looks at that first appointment and the third appointment, and that'll become more important later as we go on. But it did take into account booked appointments and appointments that were not in an open status. So, current methodology was developed in 2008, and it was developed on MHS Insight by Health Affairs. At that time, it was a Navy program, and in 2008, the Army, or in 2009, the Army actually endorsed it, and we had brought MHS Insight live. In 2010, MHS Insight was defunded, and we in fact moved the Health Affairs measurements over to the TriCare Operations Center. It is still basically running off the Health Affairs methodology, although we've had some minor tweaks to it. The TOC is developing third available report using the original methodology as just stated. It is still in the beta because we have been doing some changes to it, although it is still, again, a Health Affairs metric that they're reporting to our leadership, and that's why we need to follow it. The actual methodology is it's run daily after auto reconfig. It's basically run on your host, again, the data is brought down from your host the night before, but it's run based off an 8 o'clock in the morning run on your host between 8 and 8:30. And the reason it was set up to run at that point is, one, we wanted to make sure that those facilities that were accurately using or appropriately using auto reconfig, as all sites have been mandated to do, they got the credit for what was reconfigured. The reason it was run at 8 o'clock is we also wanted to look at the fact that if a patient was calling in after the appointment center opened, were they still able to get an appointment? Because if we just ran it at 7 o'clock, we'd pick up everything that had been auto-reconfigured, and it wouldn't mean any increased access for the patient. We still had facilities that were running out of appointments by 7:30 in the morning. So we pushed back the run time. The whole theory behind that was is if you had somebody that was working at Skyline in D.C., and they got to their office, called to make an appointment, here it is 7:30 in the morning. If they were offered a 7:30, a 7:45, and an 8 o'clock, chances are they wouldn't even be able to make it to the clinic, which again is part of the reason we postponed it to a later point, was to make sure that the availability existed other than just that first hour in the morning. It was a snapshot of the current state of the CHCS schedule entity file. It includes weekends and holidays. This has been by decision. A matter of fact, recently we had asked to drop weekends and holidays, and the reply from Health Affairs is, well, why are you not open on weekends and holidays? They are now doing a full study based on weekend and holidays and the number of clinics open and everything else, because what we were able to articulate is in several places where we built weekend and holiday clinics, they weren't being effectively used. So it was not, the bang was not worth the buck to actually have them open in some cases. We were able to articulate that, so now they wanted to see the full data study, so that's ongoing by Health Affairs right now. Daily transfer of files actually is off your nighttime run. Current methodology, clinics were rated daily as a pass or fail based on the presence of a third available in one of the provider's schedules within the Access to Care standard. Well, a lot of people don't understand what the third available appointment metric did, is it broke every appointment out, put it into category by acute, routine, spec, and well, and then measured it at that point, then aggregated it back to the individual provider's schedule after it measured if there were the 3 availables, and then took the aggregate of the provider's schedule to equal the clinic. So what that means is if you have 4 providers, and I'll be demonstrating this in a minute, that all had 2 open appointments, the clinic would in fact fail because at least one of them did not have 3 open in that access category. That was one of the flaws that the Army presented with the metric, and that's one of the things that's being mitigated now, and I'll be explaining how that's going to happen. The report third available is the number of successful observations. If you look at the monthly report, it has roughly between 21 and 25 observations, and then it'll say you passed so many. That is a roll-up. If you go into the individual, you can see where it says 4 and 500. That is not the number of clinics tested, that's the number of observations performed, and the reason the number is so high in some of the aggregates is you're actually looking at the number of total schedules that was tested. Again, it is not necessarily clinics tested until it gets aggregated up. Missed observations were not included in the count. It included provider schedules only. It included acute and OPAC under the acute care, and routine and established for routine care. Now, anybody that's looked at this metric has noticed that the way it's actually reported out today is there is a column for routine and then a column for routine established. The reason for that is the Army did not convert over to the routine established until we are able to see an additional column that we required, which is the average days to next. And I'll be giving you a demonstration of what that actually looks like, because that's the only way we could gauge whether we were meeting the Title 32 requirement of 7-day access. So we had to have an additional column added to it before we could truly accept it. And it measures primary care clinics only under the definition of primary care, which is what's posted on the top, and then includes B star, Z star, excluding numbers. Methodology challenges. The model can misrepresent clinic performance under certain conditions. What we're talking about there, it leads right into the next one. If you were using additional appointment types that were not one of the 4 primary, it didn't even count those appointment types as existing. One of the big problems with that is a clerk can grab the appointment type during the appointing process and change it at any time. So the question was posed, why? Also, weekend and holiday clinic business model was not accounted for. And what it in fact did by including weekends and holidays is you automatically failed Saturday, Sunday, and if Monday was a holiday, Monday, which was mitigated by us lowering the target for the percentage required. We understood that you automatically failed those days, and the key is if you have 20% and you're arguing, well, I missed 10% because of this, but you're 70% below the target, there's another 60% you could have mitigated, and in a lot of cases, that's where people get lost at not realizing that. Okay.
Sorry to interrupt. Phone might unmute. The folks who dialed in only can't hear you.
What's that?
I think your phone might be on mute because some people who are using the audio only access using the dial-in number can't hear you.
Okay, the people using the dial-in only, hold on just a second, what I'll do to mitigate that. Give me just a second.
Welcome. You have reached the audio conferencing system. After the tone.
Okay, those people using the audio, can you hear me now?
Yes.
Okay. The problem is there is a disconnect between my phones and my computer, and I'm trying to rectify it real quick by getting everything set to my BlackBerry. So if you can give me just a second. I'll transition to my BlackBerry at the break. Right now it's on my private cell. Okay, so this is what I was talking about a couple minutes ago when I was talking about there was a flaw to the way the metric was calculated. Because the way the current metric is calculated, in this particular clinic you have six providers, all of which have where their third available was measured at. In this particular case, you passed the measurement because at least one of these providers had 3 open appointments within the 7-day standard. So the whole clinic would have been rated as passed, regardless of what these other providers actually did, which is kind of a flaw in the metric. This is what highlights that flaw. In this particular slide, you notice you have 6 open appointments, but this clinic would have in fact failed the metric. And it would have failed the metric for 2 reasons. One, it only picked up the first appointment. You didn't have any provider with 3 available, and if you notice, you do not see a count for the second appointment. The reason being is the ad hoc, although it glances at the second appointment, does not flag it or mark it in any way. It only marks the first and third appointment. So it wasn't even giving us credit for the second appointment existing. Now what this went on to cause was several clinics saying, how is it I'm not meeting the third available appointment for clinic and I have 10 open appointments at the end of every day? Well, this is exactly why. It was kind of a mess up in the way the methodology was being determined. But again, this is still a Health Affairs metric. It is still being reported by Health Affairs. They have not officially changed the methodology, so we are still required to follow the metric as is. I'm going to be going into what we're doing to change it now. The Army actually addressed this issue about a year ago, that we identified the fact that it was measuring the provider aggregated to the clinic and not truly the clinic, which is what it said. So we went back to Health Affairs and said, you need to change that metric to either say what it does or change it to do what you're saying it does. Basically, if it's third available by clinic, you need to look at, does the clinic have 3 available, not does one provider within the clinic have 3 available aggregated to a clinic level. So we looked at a couple different ways to possibly do this. Some of the big changes that came out of those meetings is the first thing you see there is the 24-hour availability. Now this one is still in question because the Navy is pushing that it still be measured at acute and OPAC only, But as you remember, I said that the clerk can change the appointment type during the booking process, so during that 24-hour period, it kind of becomes irrelevant what the appointment type is. One of the things we had pushed for was that all appointments count. So basically what they were looking for is, does each doctor have 3 open appointments regardless of the type in the 24-hour span? Health Affairs liked the measurement, but again, like I said, we had some pushback from part of the council because everybody's going to a 2-appointment system, including the Army, and everybody should be already using auto reconfig, including the Army. There was a question as, do we really need to go that far? Because we should be within standard because of what we already said we're trying to enforce. So that is still up in the decision point for the SWIG, which is supposed to be meeting on this very soon. Then the routine care availability, we were looking at, are any 3 open appointments within the 7-day routine and established? Remember I said originally we did not accept this metric simply because it didn't give an average days to next, so we couldn't tell whether we were meeting the Title 32 requirement. Under the new way it's displayed, it does. And I'll be showing you that here in a little bit. And then it looks at providers with availability, percentage of providers, so there's now a 3rd tab. And what it's going to actually show is, based on the number of providers, what is the percentage for the clinic. So if you have 5 providers and 4 of them make the metric and 1 of them doesn't, you're at 80%. It's no longer a all-for-nothing type measurement. They're actually going to look at based on the percentage of providers. And it'll be included in the 24-hour measurement, the 7-day measurement, and that's 24-hour applies to whether we're doing the any appointment type or not. The other thing that we said is you also need to account for that 2nd appointment because we know it's there. We know that the ad hoc currently doesn't flag it. So what Health Affairs' answer to that was is they were going to impose that appointment time at the direct center of where they measured the 1st and 3rd. The reason this becomes important is, again, if we're trying to calculate are there open appointments, we need to know about appointments. So basically, as you can see on this graph here, what they've done is they've added the 2nd is inputted and counts towards the 3rd available, but it's inputted based on where it falls directly in between, because statistically when we ran the numbers, looking at where the 2nd appointment was when we did find 3, it was pretty much right in between. So now you're looking at that same clinic that failed the metric with the 6 open appointments, and now you're looking at a more logical and realistic view. This is what the clinics were in fact telling us. We're failing the 3rd available metric, and we have 10 and 11 appointments at the end of the day. How is that even possible? Well, hopefully now you understand how it was possible. It was a kind of a flaw in the methodology, and again, thanks to the field, it was the Army that actually identified the flaw. So basically what we're looking at, and this is just a summation of what we were just talking about. 3rd available is the number of successful observations divided by, so it'll still be measured that same way. It's going to include provider schedules only and primary care clinics only. The 24-hour access is going to include appointment types that can be changed at the point of booking, or because they can be changed at the point of booking. The clinic will pass if there are 3 or more appointments of any type within the 24-hour. Calculated 2nd appointment will be included, and the average calculation is based on the 3rd appointment. For the routine, we are going to the routine established. All we're waiting on is that column to become visible so you all can see it and reproduce it. We will be going to, it is a combination of routine / established measurement against the 7-day standard.
Or established.
What's that? Okay, evidently it wasn't. Okay. Clinic passes it. There are 3 or more appointments within the 7-day standard and is calculated including, again, that elusive 2nd appointment that we put in based on that average calculation of time. So what this is going to mean is we're going to be doing a couple different things. First off, I had mentioned that the provider test would be an average of the providers that actually pass within the clinic. This is kind of an example of how that would work. So in this case, there were 6 providers in the clinic. 4 of them had 3 appointments within standards, 2 didn't. So instead of the clinic being a pass under the way it is under the current metric, it would now be a 67%. Because in fact, 67% of the providers within that clinic met the third available standard. The advantages to the new methodology is it's more reflective of what is actually happening in the clinic. It's a more accurate methodology. It doesn't require changes to the data the way it's currently collected, and we were able to run it against old data. So I actually have 11 months of what this actually looks like. It makes assumptions about the second appointment for challenges. It does not solve the timing challenge, and it does not address the weekend and holiday. The weekend and holiday has to be a decision based off health affairs, and we are waiting for them to make that. For our next steps, we've recommended the adoption of the new practice-focused measures. We're pushing that the full data at the provider level be used for your guys' benefit and not to be beat up by us, because under this new way, we will actually see all the way down to each provider what they're doing. And we're hoping that that'll stay at a tactical level and not be used as a strategic point. And we're continuing research on alternative methods to count for business practices covering weekends. And one of the things we're looking at is we're looking at doing an extract of the TOC template analysis tool file, which would allow us to see what clinics actually had future schedules in, and we'd be able to calculate weekends based on that. But that's down the road. That's something we're looking at that will make this a more reflective measurement, and that way we don't have to try and mitigate by lowering the target percentage. Real quick, what does this all look like for you all? It looks like this. As you can see, you've got the rates, but then you have this average days to acute, average days to routine. That's going to become kind of a key point, because for acute, you're looking at averages that should be within the day. And for the routine, you're looking for something at 7.0 or less. Now, you're looking at old months data here. Hopefully you all can see this whole file. I've got stuff open behind it. As you can see, it goes all the way out to December. But when we drill into it, the key points we're going to be looking at are the average days to next, because that's going to give us the better indicator on where you're at. Because if you're at 70%, but your average days to third available for like routine is 7.1 days, that means that you have a lot of availability at the 7.1 days. So that's going to become more of one of the keys we're looking at. More so than some of these percentage numbers. Does anybody have any questions as to that for right now?
So there was a question about how this will affect the embedded specialist. The embedded specialist?
About the what? I'm still not hearing you clearly.
Ebony Harris is asking how this will affect the embedded specialist.
Okay, what we're doing with that's more of a PCM continuity type issue and stuff like that. Now for the embedded specialist, what we're going to be doing is secondary sorts based on the provider specialty codes. So we'll be excluding a lot of that. And the way we're working that is the TOC has already developed how we're going to do it for the PCM continuity, and we'll roll that over. Ebony, did that answer your question?
Joe, this is Janet. Can I ask a question?
Sure thing, Janet.
If you are assuming, because the clerks can change in your appointment types, why aren't you assuming the same thing on the 7-day routine? because we can change those OPECs, add that detail code, and book it as the patient request.
The whole thing with the routine is they're trying to, again, take us to the 2-appointment system. The only, there would be a couple exceptions that we'll get into during the advanced access, and those appointments should all be mitigated through the auto reconfig. So the pushback from Health Affairs was through the use of systems that, again, we're supposedly already enforcing. It shouldn't be an issue.
Yeah, but at the 2-appointment thing, I have OPEC, and I want to book that OPEC 7 days out. That gives me a routine access. So I won't have a routine, and I may not have an established, but if I have an OPEC out there, I'm able to book that patient.
OPEC shows up under the acute if you're doing the access to care search, not the routine.
I understand, but I can also add the detail code and book that appointment for the patient-centered.
Right. Well, you could also, again, anytime you override the booking standard for the acute appointment, if you put anything in that comment slide, it automatically doesn't count against you, as you know. The problem is you're eating a lot of your future access, so you need to be careful, and that's why we're going to be talking about appointment mix and how to mitigate that before it becomes a problem, hopefully.
Yeah, but I think if we assume the 24, any appointment is 24 hours, because I can change it, I can do the same thing with 7.
Your point is well taken, and like I said, the Health Affairs pushed back on that for the same reason that the Navy pushed back on allowing for any appointment during the 24-hour.
Thank you.
Yep. Any other questions on third available?
Came in over the chat. Fort Knox wants to know when this is expected to go live.
I am waiting for the results of the SWIG meeting. It was supposed to be presented at the SWIG last month. It was postponed to this next, the January meeting, so I'm hoping to hear something soon. I'm figuring hopefully in March we will actually fully go live. Again, the only reason we have not gone live with the routine/established is the file that is posted on the top currently does not include that average days to next, and that was one of our requirements. But we're hoping that this will go live by March.
Flower at Fort Hood wants to know how this applies to BMM, PCM in our active duty only clinic.
How the third available will apply to them? It's measured against all primary care. A lot of our active duty only clinics are converting into soldier-centered medical homes and everything else, and they will be maintained to standard. One of the
Joe, I'm sorry, one more time. What is the percent that we have to meet?
For acute right now, I know there's been some confusion on it. It is 62 and above is green, between 62 and 52 is amber, below 52 is red.
We keep those same targets when we go measuring average per clinic, right?
What's that?
We're keeping those same targets when we go to the new way in March.
Yes. We're keeping those new targets. Again, those are Health Affairs set targets. We change on, I've got the sheet right in front of me actually, we change in October 2014. We are currently projected to change to 68% for acute. So the rest of the scale will adjust accordingly. And for routine, right now we're at 78, and in October we are slated to adjust to 86. Again, we'll have cleaned up some of the variation by that point, so we'll have a cleaner metric so it'll be capable to hit. Matter of fact, that's low for what you'll be capable of.
So Chuck clarified his question about BMM.
Hold on, I got two questions coming in, one on the headset and one on the phone. Go ahead.
Flower at Fort Hood clarified his question about BMM and the expectation for their availability. He's saying that they are only working 50% of their time in the clinic. Does that affect how they're scored in this metric?
Is that going to affect the measurement for third available? Is that the question?
The question is how it applies to those types of devices.
Okay, it's coming in broken up. I'm hearing the question is, how is BMM going to affect this measurement since they're only in clinic about 50% of the time? Under the new FORSCOM agreements and everything else, one provider may be in only 50% of the time, and there may be a slight deviation in the percentage based on that, but we'll be able to see that relatively quickly, and since most of your Soldier Center homes are going to be under the BHZ, we'll be able to identify it and bust that out. So we'll be able to see what's causing that, and we can address it at that point. That's part of the reason we're clearing up how some of the MEPRS code data is reported, is so we can actually get a better idea of what's happening on the ground. Do I expect there to be a major effect based on borrowed military manpower? No more than what we've got right now, because we've already got that borrowed military manpower working in the facility. But at least it'll be broken out and we'll be able to see it a little better. Did that answer your question? I'm trying to guess here because I'm just hearing broken parts of the question, so I'm hoping I'm covering it.
Thanks, Joe. I'll wait and see if Chuck lets us know if he's dissatisfied with that answer.
Yeah, if not, if he can send me the actual question in email, I can address it directly. Just because when it's coming over, it's all broken up. Hopefully I'm coming through clearer to you all than it's coming through to me.
Two different folks want to know what they should be using to brief their commanders. CMS data or TOC data?
Okay, currently they're going to have to use TOC data, and the reason being CMS isn't up to date. As they get CMS up to date, it's the same report. The difference that you're finding between the CMS and TOC data is if you were to go into CMS under the Advanced tab and change the aggregation from the rolling 12 to the single month, the numbers would actually line up. It's the fact that CMS automatically defaults to a rolling 12 is what is making the data seem different. It's actually the same data. It's pulled off the exact same report. Matter of fact, it's a direct feed report from the TOC to CMS. Okay. So now we're going to discuss a little bit about appointing, and what we're going to talk about is one of the things when PCMH first start coming out, and we start talking about virtual care and virtual care and non-traditional care, is we were looking at how it could potentially affect our schedules and things of that nature. So one of the things we did is we took the existing. And this is a little bit old data, I'll admit it, it's the one I did the study with. And it is kind of reflective in the new stuff that was just on your radar reports. This kind of explains some of the thought process behind it. Is we based on populations that were outlined in the op order, we figured on an average 4.1 utilization rate, where we were able to identify in the civilian industry about 30% of appointments did not need to come in, did not need to be face-to-face. They were very competently and appropriately handled in the virtual space. So we took the 4.1 utilization rate, separated 30% of it, as you can see on the table in front of you, and ran those same numbers of encounters and everything else that you see in all the stuff that we produce. And basically what it was saying is to meet the actual population needs for a active duty FP, you needed about 13 face-to-face encounters, as long as you were doing the virtual encounters underneath it to still meet your RVU target, which we all know was kind of one of the keys. Now this was based off a slightly elevated RVU generation per encounter because it was based off Screaming Eagle Clinic when they were doing the enhanced visit as they were building their CBMH. So what we did is we got with RM and we said, okay, we need to do a couple things. First off, without increasing the population number, we know that we need to put some more appointments out there because this utilization rate we're using is based off what got in, because they were using the CHCS utilization rate and not the one out of the ECM model, which includes some of the leakage and everything else. They were using the ones out of CHCS. So what we turned around and did is, the way we were able to do that is, based off what we were seeing as leakage, the actual adjusted utilization rate actually became about 4.8. And in doing that, as you can see, what we identified was for the clinic that we ran this against, to meet their RVU target and actually exceed their RVU target, they were going to need 15 face-to-face encounters as long as they were doing the 6 documented virtual encounters. Hello? Hello? As long as they were doing the virtual encounters in conjunction with it, they were still meeting RVU targets and everything else. So where did this go? Well, what this went into is 2 trains of thought. One was we could lower the number of appointments, program in time to do virtual care, and give providers additional time in the morning and time in the afternoon where we block it and say, okay, this is for virtual time. Or what we could do is actually elongate the appointment times to give them the additional time they needed to not only see the patient, but to do some of the virtual care during existing encounters, which leads to this slide deck. Now, the 20-minute slide on here, I can tell you, this is what Lieutenant Colonel Swafford and everybody else are saying, do not follow, go away from it, because in this case, what we did is we programmed the additional time, 30 minutes in the morning, 30 minutes in the afternoon, 2 20-minute blocks, and said use a PBO to block accordingly depending on the amount of virtual care you got. Well, they said, no, what we really want to go towards is we want to go to a little bit longer appointment with the assumption that some of that virtual care is happening during the appointment blocks. So what I did is I ran a baseline template against a 25-minute and 30-minute. Here you're seeing that 15 appointments that study showed that you would have to do to, as a minimum, this plus your 6 virtuals would still hit your target RVU requirements. And here you're at about 17 at the 25-minute block. And this still accounts for 30 minutes in the morning, which allowed the providers to come in, attend the huddle, and the preliminary stuff that's required by PCMH, and so did this. Also, what it accounts for is the first period of time where the nurse is in with the patient gives the doctor some additional time to take care of some of those type of care needs without having to double it up and triple it up here, just because of the normal staggering of appointments. When you have the nurse in with the first patient, by the time the doctor goes in, the nurse is starting with the second patient, so then the doctor's going from room to room, but prior to that, there is some time where some of these issues can be addressed. It's part of the base of the advanced access theory, and that's kind of what we're going to talk about right now. We do not do open access, we do advanced access. Understand that even as we're switching to OPAC and established, we are not calling it open access. Open access means same-day appointments, and they are measured from 0001 to 2359. We are unable currently to measure in CHCS that way. We are able to do a 24-hour access, which is why we're calling it advanced access vice open access. Advanced access is the key to performing today's work. Today, it's based on the premise that providers will have enough appointments out there to meet the enrolled population's needs. It's essential for providers to have enough appointments supply to meet demand, and advanced access utilizes a simplified appointing system. It uses the OPAC and established appointments. You start with about a 60-40 split. This can be adjusted several ways. First off, if you see that you need more acutes up front, then you can shift the acutes. A lot of clinics, what they're finding is instead of needing more acutes up front, they need more established up front. So what we're telling them is, okay, they may want to invert those numbers and start with a 60-40 using auto reconfig, so as appointments move closer, that they can be converted to OPAC. The whole reason for doing this was to cut down on some of the burden on the booking clerks by trying to decide what type of appointments these people needed to be in. It's simplified appointing for the patients. Basically, do you want to be seen today? Do you want to be seen in the future? And with the auto reconfig and everything else, the reason that we had mandated that was it actually expedites the appointing process because the clerks aren't having to go in and make a lot of changes. They can be actually programmed to occur at a set time and date. Understand, auto reconfig works on all appointments except those that have been canceled by a patient, because when the patient cancellation occurs, it removes all that stuff attached. So there will be a small percentage of appointments that still may have to be manually done. Along with that, facility booked only appointments and PBOs. Facilities are directed to reduce the number of facility frozen appointments to less than 5%. The reason being is when you have a facility frozen appointment, your clerks cannot see it outside of your facility. So a lot of our facilities use centralized call centers. As soon as you put that $ on the appointment, they can't book it. It becomes a mother may I appointment. Now, in some aspects, there are legitimate reasons to do that, but we have facilities out there that have facility frozen in excess of 50% of their appointments, which are also some of the facilities that our patients are complaining the most about as far as being able to get access. They're being told, call back later, call back at 6 o'clock tomorrow morning, we'll try and squeeze you in, and things of that nature. PBO appointments shall be used in very limited cases only when it's restricted by equipment or availability of a certain provider type mandated. Previously, you can see the sub-bullets there. It was one of the things that we were saying you could use to block non-virtual time, or virtual care time. But under Colonel Swofford's current guidance and Colonel Goodman, or Mr. Goodman, I'm not sure which status he's in right now, his guidance, they want that time to actually be allocated within the schedules, which is what that 25 and 30-minute allowed for. Facility use of PBO will not exceed 10%. Again, once you have a PBO on it, you limit the booking capabilities for the clerks. You limit the access for the patient. Use of detail codes that also limit is keep the detail codes down to the bare minimum required for an appointment. There are times where you still need to use them to mark appointments for certain things, but it should be the bare minimum required. Taking us to other appointment types. I threw TCONs and secure messaging in here just as kind of a space to make sure that we at least covered it. Remember that this is part of the virtual care. This results in freeing appointments for other beneficiaries. The more that we can handle in the virtual space, the more patient issues we can actually take care of in a more constructive and more productive way. Because in a traditional appointment time, we can actually usually handle 2 or 3 type appointment issues of the virtual type, which allows the additional patients to get in. The use of the group appointment can be utilized in appropriate cases. We definitely need to watch it, but it can be used as a way to increase access for like diabetes counseling, stuff like that. When you can do the more than one-to-one association, by all means, group is allowed. Well and procedure appointments, again, should be extremely limited to when qualified personnel or equipment is not routinely available. Now, I say they can be used because we've authorized Method 4, but we do expect you to be booking to Method 3, which is a 2-appointment system, which is OPAC and established. Again, all of these other appointment types should be used at a bare minimum. The only reason I bring up specialty appointments is because we have several facilities, and pediatrics is the big department, where they have pediatric subspecialists or just the pediatricians that also do a good portion of their time as specialty consultants. So in those clinics, one, their referral capability has to be turned on, and 2, to separate their specialty workload from their primary care workload when they are also a PCM, which is the only time this would apply, you would use spec appointments. Again, if the spec appointments weren't being used, they could be converted to an OPAC so that they could get additional patients impaneled to them in. But by having the spec appointments out there, you could have the family practitioner refer the patient over to pediatrics in that example. Specialty appointments in the medical home do not apply to the embedded behavioral health specialist. Behavioral health guidance came out saying that they would maintain the OPAC and established, and the way that they're meeting the 7-day requirement is because they are embedded in the into the medical home. The gatekeeper in that instance actually is the GPM. What the actual health affairs policy says is that within 7 days, the patient will be given an appointment which can be performed by either the PCM or the behavior health. So they're working under the assumption that that first appointment has occurred, and then they are taking care at that point. or they are taking over the encounter at the time the patient is in clinic. Does anybody have any questions about that so far? Okay, so that takes us to just a couple other things I wanted to cover really quick, which is, this is the notional diagram of the PCMH model, and this is, I'm going to cover a couple areas where people are not following through on their naming conventions and stuff like that. The naming convention becomes very important for under the PCMH model. As you can see, right here in this block, I've indicated that the group and place of care name are the same. It's a one-to-one association, one group to one place of care. It's no longer a single group with multiple places of care. This is a health affairs mandate. The reason we've done this with the naming convention is, as you can see down here where the breakdown of the naming convention is it allows those of us that do have to collect the data to be able to efficiently sort it quickly. The AMH is what tells all systems that it's a medical home. That includes things like the up-and-coming null, and where that becomes important is if they get a call during business hours from an AMH patient, they're supposed to refer it back to the medical home. So this is an indicator, crosses all systems, and that's what it's being used for. The F, or in this case it could be FPI, M, C, or S, C for primary care and S for soldier-centered medical homes, tell us what type of medical home it is, which helps us, again, sort the data. There was a question about borrowed military manpower and everything else. If it's occurring in a soldier-centered medical home, that's one of the ways we're going to sort some of that stuff out. Then the 01 tells us the practice. So as you can see, this is actually one practice. So I know that if I want to see what the medical home's doing, I look at all the way out to SEAL. If I want to see what family practice 1 is doing, I can stop right there at AMHF01, pick up A and B, or if there's a C, I would pick up C also. In this case, there is for fish. And that would tell me what my practice is doing. And then the seal, shark, and fish, those are simply for the clerks, to make sure that the clerks can associate with the teams properly. A lot of clinics, what they're using is that as a shortcut key. So the clerks just have to look for Team Seal, Team Shark, Team Fish, which is very easy to set up in CHCS. Any questions on that? The biggest problem we're having right now is the consistency with the naming convention, and I can give you a quick preview on what I'm talking about there. I am in the process of doing the update for the CG right now, or the TSG, and this, as you can see, a lot of it's incorrect naming convention, incorrect naming convention, incorrect naming convention. Place of care is correct, group name is wrong. So, I mean, a lot of that is key to what we're trying to track. To give you an idea of how it should look to make it easier to follow, this doesn't mean I like you, Evans, but Evans Clinic is a perfect example of how the data is set up right. I can sort out who's with Pediatrics 05, which they have 2 teams in Pediatrics 05. I can sort out the 4 teams in Family Practice 01, being A, B, C, and D and E, so 5 teams. I can sort out the Internal Medicine Practice 06. Again, this is why that naming convention becomes so important. And again, it's one-to-one association, so whatever you have as your group is also what you have as your place of care. Any questions on that? Okay, that being said, that takes us to the final piece, which I was being asked, where do we get a lot of the access to care data? Again, we get it off the CMS, we get it off the TOC, we get it out of M2, and this is the TOC for those of you that aren't familiar with the TOC. It's the TRICARE Operations Center. In the TRICARE Operations Center, you get reports similar to the book management report. You get the appointment utilization report if you wanted to know how many appointments, what percentage of your appointments go unfilled. At the end of the day, you can find that there. Access management report is going to give you the walk-ins, the left without being seen. Do not use the no-show data off this. Use the no-show data off the AKC website, please, because we do an additional sort to sort out some of the care that's actually occurring in clinics that aren't clinics that are associated with the ER, not primary care. Then under the data reports, here's where you're going to find that third available. They do a third available by day, third available by week, and third available by month. Daily is of little value. Weekly is of value, but please understand that it still contains some end-of-day processing issues and everything else until it is rolled up to the monthly. So you can't just take your weekly, add them together because there's some additional data that you may have missed in between. The appointment activities tool gives you, again, it tells you kind of what happened with the appointment status, shows you things of left without being seen, no-show, things of that nature. I suggest you all get out here and play around a little bit and get very familiar with these. One of the reports that you may want to be looking at is this detailed usage code. Recently I showed a facility how to use this and they realized how many PBOs they were actually using. I mean, that's kind of important to know. If you look at your book management, you can see how many facility frozens you're actually putting out there. Net discrepancy is also your PIT discrepancy report. Under PCM capacity and assignment, that was the one I just kind of drilled into to show you the file table builds, but it also tells you what you're saying your enrollment capabilities are based off your CPRO and PPRO builds, which are your provider profile and your clinic profile builds. Then you have your PCM by name report. Now to get to your, whenever you open up and you see a screen similar to this, please don't be using these files here. These are the strategic level, and they will not get you the granularity of data you need. What you need to do is go down here to where it says Army, and this is in all these areas, and then you pick your specific facility. Let's go with, I was talking to Martin this morning, so we'll use Martin. Now, in this, there's a couple things that we can gather from this report. First off, let me close it up a little bit. And this is to go asking, again, to the questions that were in the pre area of where we get some of this data. So one of the things I can see here is, first off, again, I can look and see how your naming conventions are aligned and things like that. The other thing I can do is I can sort several different ways. I can sort by the provider group, but that should be almost synonymous with the place of care. I can sort by the MEPRs, or I can support by the DOC. Now, the reason this becomes important is right here. If I wanted to see, one of the things I talked about was leakage, where patients were leaking. Now, looking at this report already, I can see two things. I can see the fact that they were in the middle of conversion during this month, and the reason I can see that is the only way that this provider should have had PCM continuity in 2 clinics. You shouldn't have numbers in this first column in more than 1 clinic, because you can only be a PCM in 1 clinic. In this particular case, Yellow Group was in the conversion from BGAA to BGZD, so that explains why that occurred. The other thing I can see in this is it's not that Dr. Atkins is actually assigned to all these clinics. He's only assigned to this clinic here, or at that one time that clinic there. So what's happening in B, C, and V? Does anybody know? When you come over here and trace, what you'll find out is those are patients that fall into these categories over here of when the provider either not seeing their PCM or not seeing somebody in the same team. And a lot of that falls into these categories over here. And then you can see that although the numbers look kind of skewed, it was only 3 patients that actually leaked. 2, 3 patients. And those 3 patients of his were seen in BDZB, BDZC, and BHAV. So I can see where his leakage went. Now somebody was saying, how can we tell if our providers' appointment schedules are being maximized? Well, you can see where you're leaking internally, and you can also look at what you're leaking externally. And then you can look at the unbooked appointment rate for that doc, and you can go accordingly. First off, one of the things I would do is match his empanelment to what his schedule says. And part of the way you would do that is through some very simple equations that a lot of you are familiar with. We're not going through this whole slide presentation. I just wanted to bring it up for equation purposes. Down across the bottom here, I mean, is the basic formulas for how to figure out what your panel size should be and how many patients you should be seeing a day. And once you figure out what your panel size should be, and again, those numbers are changing based off what's going on with the work group with Colonel Goodman, or Mr. Goodman. Once you figure out what your empanelment is and how many days you're in clinic, you can figure out how many annual encounters you need. Then you break that down by the days you're in clinic, and it tells you how many encounters you need a day to meet based on the utilization rate your population's needs. So it's not a very complex equation. Backed out, the other way you can do it is you figure out how many days they're in clinic, how many hours they're in clinic, how many patients do they see an hour, and you can come up with how many visits they're supposed to do at that point too. There's a couple different ways you can look at that. That being said, are there any additional questions, Sarah? Hello? Is anybody still there? Okay. Sarah, did you have questions for Amy? Want to open up measure 8. They're going to be Stephanie from Fort Drum, you're going to need to send me a copy of that because I haven't seen Warren. So I'll have to look at that and see what's going on with that. Can you zoom in on your slides? These are impossible to read. My slides were actually as big as I could make them. It shows the same thing as an on the ample guidance. Marty, I will get you the slide.
That's hard to see.
It shows the same thing and guidance.
Some of Also something else.
Hey,
We'll
Wednesday?
get that up to probably Monday. Okay, that's great. Okay.
Today's Wednesday?
This is Carla Graham from Fort
Why is
Worth.
it Jack Show? It says
Can I ask a question?
Tuesday.
It's something that we...
Several of them actually are, but what I'll do is I'll throw something up. We won't get that up till probably Monday.
that we deal with it in places like...
Okay.
It's something that we are... As far as the time frame of appointments, you can... With that, what... If you know you're doing physicals on Tuesday, that we deal with is on flight physical needs. Flight physical. Physical.
As far as the time frame of appointments, you can. If you know you're doing physicals on Tuesday after, you can make those support the flight physical needs. You can. And make sure it's. Again, that's what kills us a lot is we don't do our booking protocols correctly, and our clerks book kind of whatever they want.
Carly, you also want to add the detail code GDDL on those. Say again?
The GDDL, it's going to do two things. One, it's going to stop booking from TOL, stop people from TOL being able to get the Part 2 physical that haven't had a Part 1 yet. Because it'll make it invisible on TOL, and it doesn't count against you.
Again. Questions?
Okay. I'm trying to switch this on my
That 113
again.
comment on it. I need to see what it actually says.
This is Sarah. Can you hear me now?
Yep. And
Great, thanks. Another question came up earlier. Translation.
that 1013
You're going to release
comment on it. I need to see what it actually says.
Great, thanks. I never reached the last guy. And future assignments, which allows you to not rely on because you only like 2 or 3. So that's stuff like that. Already released and yes, I will.
Just like I've released the last ad hoc, I released and future assignment, which allows you to not realign them. It gives you a frame like 2 or 3. So that's stuff that I've already released, and yes, I will.
The 1399. I'm happy to put to see around to someone to send me a copy.
I missed that comment. Oh.
Everyone wants a copy, and I said that I would post it to CMS with your files if someone sends it to us. Well, I'm going to get for your email address.
Thank you, ma'am. Were there any other questions? Okay, not hearing any other questions, Sarah, I'm going to turn it back to you.
Okay, so, if you can keep your microphone on, that will help me. Someone be in the chat, please hear me? Yes. How about okay, folks.
Folks, if you can hear me, thanks for attending today's session. Our next session is going to be next Wednesday, and what it's going to be is Colonel Goodman, who's still Colonel Goodman, is going to present his vision for the future for Army medicine in our current fiscal situation. So I'll send out the invite for that. That's going to be next Wednesday at 1300, same Aspire Series DCO room. It's going to be a good one. I hope you can make it. Second, I've just put the post-course survey in the chat pod. Please take a minute, and it's really just 3 or 4 minutes, to fill out that survey. I really appreciate it. It helps us get some good feedback. It also allows you to rate the technical quality of this DCO, and I understand that we've had some trouble today. I do apologize. We're trying to bridge it between DHHQ in San Antonio and also try to work with DCO and its kind of limited capacities these days. So thank you for bearing with us. We do appreciate it. And I will post these slides and the additional slides to CMS this afternoon. And Stephanie, if you could send the Warno to Joe, I will post that to CMS too. Thanks for attending. This ends this Aspire series. Have a good afternoon.